Thank you, Dr. Lolwa, for the kind introduction, and thank you for inviting me for this very interesting meeting. It's a great pleasure to be here today, and my duty today to be highlighting assessing muscle in MASH, what tools that we have in our arsenal. Basically, I'm Ahmed Cordie without any disclosures related to this presentation. And at the introduction, we all know that the muscle D nowadays is the most common liver-related comorbidity worldwide, and specifically in the region of the Middle East and North Africa. Also, we all know that the intertissue talks between liver, adipose tissue, and the muscles play a fundamental role in the pathogenesis of muscle D. So we have a lot of types of muscle affection while we are talking about muscle D. It can include insulin resistance, myosteatosis, or sarcopenia. We can start it from here. When we have a person with obesity or type 2 diabetes, so we have adipose tissue dysfunction. So we have lipolysis and increased free fatty acids, and this will result in the activation of toll-like receptor 4 and 2. This can also be induced by the bacterial lipopolysaccharides getting from gut microdysbiosis, and also the liver will release some hepatokines which will also activate the toll-like receptors under the metabolic stress. This will end in the phosphorylation of the insulin receptor substrates, and it will block the glucose transporter type 4 from uptaking glucose. There's also recruitment of macrophages, increase the production of the tumor necrosis factor alpha and for the interleukin 6. Also, there is oxidative stress under the effect of hypoxemia by the expanding fatty tissue. So we have some sort of disbalance between adipokines and leptin. So now we have what we call insulin resistance. Under the effect of insulin resistance, the adipose tissue will not be able to uptaking the free fatty acids, making fat. There is more lipolysis. So we have more free fatty acids, more glucose, and more insulin available for the liver. On the other side, in the muscles, also the insulin resistance will prevent the muscles from uptaking the glucose. So we have more hyperglycemia, more hyperinsulinemia, and also there is imbalance in the myokines, the myostatin and the myonectin produced from the muscles, more myostatin, lower myonectin. So they be reflected on the muscles by causing muscle wasting and decrease muscle regeneration. Then they travel to the liver and induce more steatosis and activate the fibrosis process. Also, we have reduction in the irisin level, which is related to the related immobility and the lack of physical exercise with the persons with obesity and muscle D. So here we have the liver with the insulin resistance. So the insulin is not able to stop the liver from producing more glucose, but still it's allowing the liver to be uptaking the carbohydrates and making free fatty acids. So we have more intrahepatic free fatty acids. It can be transformed into triglycerides, then released to the blood as very low density lipoproteins. It can also go for the mitochondria for the beta oxidation. But when these pathways are overused and overwhelmed, we have the fat stored in the liver, and we have activation for the oxidative stress and the inflammatory pathways. Besides the muscle-driven myokines, we can result in liver scarring and fibrosis. This liver, under metabolic distress, it will produce more hepatokines that will cause muscle insulin resistance. So it is like a vicious circle. And also the liver with scarring will start to produce microRNA 12022 and the tumor necrosis factor alpha. This applies what we call a molecular brake on the mTORC pathway, preventing the muscle regeneration and causing muscle wasting. This is hand in hand with the increased level of myostatin, causing sarcopenia and frailty. Muscles have available free fatty acids and extra glucose, so we start to store the fats inside the muscles, causing myosteatosis, inducing more insulin resistance, more inflammation, and more loss in the muscle power. So basically now we have two clinical phenotypes of the skeletal muscle affection with muscle D. We have myosteatosis and we have sarcopenia and associated frailty. Myosteatosis is estimated to be affecting around 24% of the persons living with muscle D, and 10% will be complaining of sarcopenia, and the dual muscle affection will be affecting around 14%. And this has the worst outcome. We use the CT as a gold standard for assessing the myosteatosis. at the level of L3. Also, we can use the thigh ultrasound imaging as a semi-quantitative measurement for the myocytotic burden. The MRI is a perfect tool. We cannot use DEXA scan or the bioelectrical impedance analysis because they are assessing the muscle mass, not the muscle quality. And for sure, the muscle biopsies are a little bit invasive, not feasible for the routine clinical work. Sarcopenia is combination of loss of skeletal muscle and the loss of skeletal strength. And it can be reflected in the form of frailty, reduced physiological reserve, increased vulnerability to the health stressors. When we come to sarcopenia, we need to know that it is common with muscle D than any other related liver comorbidity or liver disease. And we can start with simple screening tools and questionnaires. When it is positive, we can go for confirming the altered function by the hand grip strength or the chair stand test. When it is positive, we have probable sarcopenia. Then when we confirm the reduced muscle mass, we have confirmed sarcopenia. Then when we go for better classification or staging, either we have functional disability, we have any other related cardiometabolic complications or not. Then at this point, we can move to the core of the presentation. We need to be talking about the muscle tools that we use in the clinical practice of a pathologist. The first thing, we can use the muscle as the primary indicator for the diagnosis and risk stratification in muscle D. This data coming from the liver meeting in 2024. And you can see here 3 abstracts highlighting the following. We can be using the dynamometer to assess the hand grip strength to predict the liver-related fibrosis and the stiffness. Also, assessing the muscle fat, the myosteatosis, using CT, MRI, or ultrasound, can independently predict the risk for all-cause mortality in the persons with liver-related steatosis and fibrosis, and the quantification of liver fat in this study didn't do. Also, the calculation of the muscle to fat ratio was acting superior to the simple BMI and simple weight analysis for the prediction of the disease progression. Also, we can use the muscle as a monitoring tool. As we have stated before, we have the level of hepatokines and the myokines, the interplay between each other. So we can be using some of this hepatokines like phytoin A and the fibroblastic growth factor 21 and interleukin 6, which all increased in the persons with muscle and MASH. When we have successful intervention, it will significantly decline. We have the irisine with low level in the people who are physically inactive. So when we have got adherence to physical activity and exercise, so it has significant improvement in this personnel. So what about the 2025 meeting, what we are talking about what was presented in Washington? A lot of abstracts highlighting the use of the skeletal muscle for diagnosis, for risk stratification, and for the monitoring. But let me focus on this one. This one was talking about the mass score. It's integrating the muscle volume and the muscle quality into a single predictive value, and they found that it was been identified as the strongest independent predictor for the future liver-related decompensation and all-cause mortality when we are combining the mass and the quality of the muscle. Also, in the persons with chronic advanced liver disease, they have some sort of hyperammonemic stress, and this can be inducing high level of myostatin and in applying some molecular breaks in the mTOR-C pathways, causing muscle wasting and causing liver fibrosis and steatosis. The same also was reported with the liver-driven extracellular vesicles containing microRNA 21, and also for the same was previously described for the tumor necrosis factor alpha. And that's why we always talking about the mTOR-C1 pathway when we are addressing a treatment strategy using the muscle as a therapeutic organ. For example, when you encourage the resistance exercise, you are activating the mTOR-C pathway. When you encouraging the aerobic exercise, you are improving insulin resistance. You have some pharmacological interventions. They can try to remove the brake in the mTOR-C pathway by reducing the hepatic inflammation. And they also decrease the insulin resistance, but namely GLPs can result in the loss of lean body mass, and this can be antagonized by increasing protein intake besides encouraging the resistance exercise. So from this, my take home, firstly, I'm sorry, and also from the 2025 meeting, there was also a pilot study talking about supplementation with branched chain amino acids and calcium and vitamin D for improving hand grip strength, muscle mass preservation in the people with muscle-related cirrhosis. Also, the exercise triggers the muscle to be releasing the muscle-driven extracellular vesicles containing the fibroblastic growth factor 21, which is basically the idea of the fluoxetine Dr. Noureddin was highlighting as one of the most promising treatment for muscle D. So basically, my take-home message here is the data from AASLD 2025 is confirming that the assessment of muscle fat and myosteatosis, what we call the adverse muscle composition, is a stronger predictor for MASH severity and related fibrosis than only simple sarcopenia or weight. Also, the liver can be applying like what we call systemic anabolic inhibition on the muscle upgrade and the muscle regeneration through suppressing the mTOR pathway. And that's why when we are doing a treatment strategy, we need a combination therapy, liver-directed to be reducing the inflammation, and the muscle-directed by resistance exercise, targeted supplementation to be releasing the brake in mTOR pathway. And for sure, all the future directions in all the disciplines is talking about integrated care. And that's why the AASLD in 2025 guidance formally recognizing the sarcopenia screening as one of the most important prognostic requirements while you are providing care for persons with muscle D. Thank you.